Okay, welcome to everyone. I hope you can hear me well. My name is Frederick Joly. I'm heading the ESO Foundation, and before we get started, I would just share with you a couple instructions to make this meeting run smoothly. Let me share my screen. Okay. So this is the second session of this OESO-SEMPIRE virtual educational channel. And today's session will be run from Stanford University. And I'm grateful to John Clarke, George Triadafilopoulos, and Dan Azagury to organize this event together with Micaela, Afrin, and Thomas, to whom you'll be introduced shortly. So today we have 63 participants who registered in 23 countries. And just a few rules for you. To make it interactive, it would be nice if all of us keep the cameras on and the microphone muted. And if you want to raise a question or a comment, you have two buttons you can click on. One is the chat button, or clicking on the raise hand button, and then we'll give you the floor as soon as we have an opportunity. Yeah, otherwise I will keep you muted, so don't be surprised if you're muted by default. So here on the bottom of your screen, you should see the mute and mute button, camera on, camera off button. To raise your hand, you need to click on participant, and you have a button here, raise hand, and the chat button is over there. Before I hand it out to Robert, please just be aware that this meeting is recorded. So if you are not willing to appear, just switch off your camera. And I will let Robert introduce the first part of this meeting. So Robert, we can't hear you. Maybe you can unmute yourself. Robert, can you unmute yourself?
Can you? Is it
yeah,
okay?
We can hear you now. Yeah, great.
Yeah. So just very briefly to say that the launching of the ESO-SEMPIRE new initiative of a virtual educational channel took place on May 28, thanks to the Pilot Center of Milan, thanks to Luigi Bonavina. And it can be said that this initiative was a success, which we can say was a complete success, if I refer to the enthusiastic comments I received on my side. The virtual educational channel is a new tool of ESO and ESO-SEMPIRE with great educational potential. Today, the channel will benefit from the organization of a session by the prestigious University of Stanford, with a team represented here today by George Triadafilopoulos, John Clarke, and Dan Azagury, and, which is very important also, a junior faculty consisting of Micaela Esquivel, Afrin Kamal, and Thomas Zikos. We are going to attend a captivating presentation, I think, which will be recorded thanks to the ESO Foundation and the President, Frederick Joly. I know that several Brazilian colleagues are with us today, and we know how accurate they are with Chagas disease and the problem of achalasia. And I am glad also to welcome here today, I hope, our current president, Professor Daniela Candiolare. I am counting on your numerous commentaries and questions that will punctuate each step of this presentation by the team from Stanford with the expert multidisciplinary panel Tom Clarke has invited today. Thank you for being here. And Frederick, I give you the word.
Thank you, Robert. So as I said, we have the chance to have a great panel today. May I hand it over to you, John, to introduce the team and the panel for today's session. Saying, John, we can't hear you. Great, now you're unmuted.
Sorry about that. So I will start to share my screen here. We have a great panel, and I'm going to let George start off with the introduction of our team and to say a few words, and then George will pass it on towards Dan at that point. So I will pass it over to George now.
Thank you, John, and welcome everybody to this meeting. This is amazing times, but it has given us the opportunity to share cases, to share thoughts and knowledge with everybody around the globe. As you know, the concept was basically started when we were all together in Palo Alto and we wanted to create an international community of people, both surgeons and gastroenterologists, who are interested in esophageal disease. And this is an opportunity for us to share this and start a new concept, which is using telemedicine, basically. I wanted to introduce you to 3 members of our junior faculty to emphasize the concept of multidisciplinary approach to esophageal disease, and particularly integrating medicine that is gastroenterology to the field of esophageal disease and working together with surgeons. And this is a concept that we started and it's growing very fast. So today I'm going to introduce you to 3 junior faculty members, 2 from gastroenterology and 1 from surgery. So Micaela Esquivel is one of our surgical members, and 2 other members, that is Afrin, Kamal, and Tom Zikos, are 2 of the gastroenterology members that you will meet today. Under the leadership of John Clarke and Dan Azagury, these 3 people that you will meet in a few minutes have started their careers with emphasis in esophageal disease, and I'm proud to be part of that effort and to be hopefully their mentor to a degree or another. And I'm looking forward to their presentation of this case that John has highlighted below. I would like to take also the opportunity to thank our surgical colleague and director of the surgical side of the program, Dr. Dan Azagury, who together with John Clarke are running the entire center that we have at Stanford. And I hope you enjoy this presentation. Dan?
Thank you, George. And good morning, good afternoon, good evening, everyone. It's great to have people represented from around the globe, and so is our fantastic panel. I would call them a world-renowned experts, or you can call them the usual suspects of ESO, and these include a series of experts to be faithful to the ESO tradition that have multidisciplinary expertise. And we will start with our GI colleagues, Walter Chan, well-known expert from Harvard, who has expertise in motility and physiology. Robert Bachara from Ontario is a POEM expert. On the surgery side, I don't know if any of these people need an introduction, but I will do it nonetheless. Lee Swanstrom from Portland and Strasbourg. Roger Tatum is going to join us from Seattle in about 15 minutes. Special thanks to Kenrick Murayama, who is joining us from Hawaii. So it's about 4:15 a.m. his time. So Kenrick, thanks for joining us. And on the other side of the globe, Erwin Reeder from Vienna is joining us at a little bit more reasonable time. And our last expert, who needs no introduction in the field of pharmacology. Joining us from pharma is Carmelo Scarpignato, who will be joining us in a few minutes. So, like, without further ado, we will hand it back over to John and our faculty for the case presentation.
Okay, thank you, Dan and George. I am going to move on towards the next slide, and we have a case that I've seen in clinic for the past few years that has had some interesting transitions along the way, but also is at a branch point in his care now where I'm not quite sure what to do next. So I am interested to get the group's opinion to help guide next steps in this case. So without further ado, we'll start the case, and I'll pass things towards Micaela.
Great, thank you all so much for having me. So our case, as Dr. Clarke mentioned, we started kind of in the middle of the patient's care. So our patient's first encounter was May of 2017. Prior to our visit, the patient actually had 4 years of slowly progressive dysphagia to solids as well as liquids. He had associated retrosternal chest pain with his dysphagia. He had lost 40 pounds within this time period and had an Eckhart score of 7. At another facility, he underwent his initial evaluation, which included an endoscopy, upper GI barium study, as well as esophageal manometry. On endoscopy, there is reports of esophageal spastic motility on report, but otherwise the esophagus was grossly normal. The random biopsies were also unrevealing. Barium esophagram did reveal significant esophageal spasm with retention of contrast within the esophagus, and manometry was consistent with type 3 achalasia. So the patient was ultimately diagnosed with type 3 achalasia in the summer of 2016. So nearly 2.5 to 3 years after his initial onset of symptoms. And again, this patient's a 68-year-old gentleman with a BMI of 30. You can see here from this list of comorbidities that it is quite extensive, though I am going to name several of these just so we can all kind of feel that burden of his comorbidities, similar to what we felt when we first saw him. So the patient has a past medical history of arthritis. He's required several knee and shoulder operations, has a history of asthma on medications, otherwise controlled, has a history of cervical spine stenosis, has had 2 prior spinal fusions, as well as coronary artery disease. He's required 2 prior stents and angioplasties, spaced about 2 years apart. A history of chronic fatigue and possibly fibromyalgia. He has diffuse body soreness and pain, chronic sinusitis, as well as diabetes that's complicated by peripheral neuropathy, currently controlled, though he is insulin dependent. History of gastroesophageal reflux, high cholesterol, high blood pressure, obstructive sleep apnea, as well as a history of a seizure disorder and transient ischemic attacks. Of note, he does have a remote prior history of several infections you see here: dengue fever, West Nile virus, as well as diverticulitis that ultimately did require a sigmoid colectomy. Okay, next slide here. I won't list all the medications as I did his past medical history, but you see the extensive list here. Of note, we see that he is, again, as I mentioned, insulin dependent. He continues on a baby aspirin daily. We see that he's on chronic pain medications that include narcotics such as oxycodone, as well as baclofen, and he was on a daily PPI. I see the pantoprazole there. Our patient does smoke marijuana regularly, used for his chronic pain, used for medical marijuana with rare cigar use. And we see from his family history, a history of heart disease, diabetes, as well as depression and bipolar disease. And of note at the bottom there on review of systems, you know, it states pan positive, but ultimately he really had from head to toe significant kind of ongoing symptoms. Okay, so, you know, there's a list of questions here. Just to start us off, I will list them, and I would like for your experts to try to dive into all of them, even though I'm listing them at once. But just to start us off, what is your preferred initial therapy for achalasia? How does manometry subtype factor into your decision? How would you treat this specific patient? And what do you do to counsel your patient regarding rates of risks, benefits of standard achalasia interventions, and how do you consider his extensive past medical history into this treatment algorithm?
Sounds good. Thanks very much. That was a great presentation. Why don't we start with Lee? And if you could maybe just talk about your initial therapy for all comers with achalasia, and then what the subtype factors in your choice of which approach.
Sure. You know, I have to say that a thorough workup is mandatory. All these symptoms are rather vague, as kind of indicated by the fact that the only tool we have is the Eckhart score, which is vague in itself. So I think, as mentioned, you know, manometry, upper endoscopy, this patient kind of almost sounds like potential for cancer or something like that, so we want to rule all that out. I don't routinely get pH studies in these kind of patients. This guy's on PPIs. I presume that they are not effective, but certainly motility and upper barium study and an upper endoscopy would be mandatory for all this. I have to say that this patient is like, has red flags all over him, and certainly from the outset, I would not be thinking about surgery for somebody like this. Lot of high risk warning things. Cigar smoker that also takes medical marijuana, things like that make you very leery about doing some irreversible interventions on him. But that's kind of how I would be going into this whole thing. I think you asked also, you know, kind of my default treatment for achalasia, and most people would be endoscopic, POEM, and then I talk myself out of it by different factors. But I'd say that in 2020, default treatment probably is POEM, and then you look at risk for GERD, you look at tolerance of GERD, etc., and adjust their final recommendation according to that.
Thank you. If we could go through and ask the rest of the panel their thoughts about first off their preferred initial therapy for achalasia in all comers, and then second how subtype factors into that, and then third, what they do in this particular case. And just to add to this patient, he did take opiates, but the opiates he took were only on a PRN basis about once a week total, and he had stopped that entirely for his testing. And he did have about 15 pounds of weight loss with this. He had a pH test as well, which was negative. So I'll stop here, and if I could ask the rest of our experts to weigh in upon this.
Yeah, John, this is Roger. I can go ahead and go next. I really agree with what Lee just said, particularly with respect to the red flags issue. You know, I certainly would be considering a surgical approach in a patient like this, but there are so many other factors in this patient's history, and there are enough things that make you concerned that this patient might have a less than ideal outcome from whatever approach you tried. This might even be somebody where I would consider, why don't we see what happens with you know, a Botox injection and see if they respond to that. If they respond positively to that, then it might be worth considering surgical intervention, you know, down the road after, in addition to all the workup that Lee already mentioned, a thorough preoperative medical risk assessment. Well, with respect to the question of POEM versus another approach such as laparoscopic hilar myotomy, I don't do POEM myself. I've certainly referred patients for that, particularly patients with type 3 achalasia, although I usually go through a discussion of the pluses and minuses of each approach, with some discussion of the uncertainty with respect to post-operative reflux after the POEM, but tell people that there is some evidence, though not what I would consider great evidence, that type 3 responds better to POEM.
Yeah, John, this is Ken Moriyama. I would agree with everything that's been said, in particular the issue regarding type 3 and the POEM procedure that Roger stated. One of the problems we face in Hawaii here is that no one does pneumatic dilatation and no one does POEM here in Hawaii. So a patient like this, we would strongly consider referring to a center that does POEM. And obviously when they see his problem list and his medication list, they're going to wonder why we sent the patient to them. But clearly I would not go to surgery as a first line on this patient for sure.
So I'm Rob Bishara. So I agree in terms of the details specifically to this patient, in terms of the red flags and kind of being a bit reluctant in terms of doing anything irreversible in them. In terms of kind of the initial therapy for all-comers achalasia, I usually leave it to the patient to decide. I still present pneumatic, I still present POEM, and I still present a laparoscopic Heller as an option for them, and kind of, again, tell them the risks and benefits of each in terms of the duration of hospital stay, etc. For type 1s and type 2s, I usually say they're pretty much equivalent in terms of efficacy. However, the type 3s, I do generally recommend that POEM being kind of a first-line treatment for them. But for the most part, I leave it to the patient to decide kind of which options or which treatment they would prefer. And for the most part, most of them choose POEM. There's some that choose the pneumatic, particularly the type 2s. But even those, for the most part, all of them usually choose the POEM procedure. The other factor I take into account, which you don't see often, but some of them do have a significant hiatus hernia. There's been a couple of those, and those I generally suggest surgery and repair of the hernia as well at the time. But that's kind of my general approach to kind of the all-comers.
Maybe I can add a little information. I recently did a few patients, maybe it was 3 or 4, where 2 type 3 achalasia and simultaneously had reflux on their page study. And I did a POEM and then 1 POEM and together with a laparoscopic door fundoplication afterwards. All of them do great so far. Has been 6 months so far, so no long-term data so far. With this patient in particular, I have a big red flag like the fibromyalgia diagnosis. I had a patient once which has a similar diagnosis. We see every other month with difficult complaints and didn't relieve the symptoms at all. So this would be my first really red flag. So don't do any first initial standard procedure on them.
Okay. Well, thank you. Well, this case was worked up at a different institution than ours, so we can't claim credit for next steps. Though I will say the site that worked him up is a great institution with great people, and we'll take it from there in terms of the next steps. So I will pass it over towards Dr. Kamal for the next several slides.
I think I might have maybe 1 or 2 more slides. So,
sorry.
Taking the mic back. I'm just kidding. So as Dr. Clarke mentioned, this was ongoing and workup at another facility, and ultimately, as many of the experts mentioned, the patient did undergo POEM in October of 2016 along myotomy of approximately 20 centimeters. Following this intervention, the patient's dysphagia as well as the patient's chest pain readily resolved. So the patient developed pretty much debilitating heartburn and acid regurgitation soon after the POEM. He didn't see any improvement on BID, PPI therapy. Gastric emptying study was normal. And this kind of prompts us to the next question for our expert panel. You had a very short break there, but in regards to, how often in your own practice do you see reflux after POEM? How does this compare in terms of all-comer achalasia kind of procedures, and how do you typically manage this?
Okay, and so we'll take these questions, and if we could re-ask again the panel, why don't we start this time in a reverse order if we can?
So in terms of how, I think the issue of reflux after POEM and even after Heller-Dorr is same, really controversial. I think the big issue is the definition of it. And that's always been a problem in terms of what definition of we're using for reflux after POEM. Depending on the definition you use, the rates are going to vary quite drastically. Are you just using 24-hour pH? And if you're using 24-hour pH, what are your cutoff values? And again, those can be variable as well. So, or you're using esophagitis, and that again, sometimes after POEM, you may see very mild LA grade A or B esophagitis in the area of the tunnel. You'll do a 24-hour pH and it's normal. And again, do you classify those as reflux esophagitis, or what do we classify those as? So I usually, in terms of the definition I use, I try to use the Lyon classification system for it now. And in terms of those that end up requiring PPI afterwards. So the rate I usually see is about 20 to 30% of the patients end up requiring lifelong PPI, has been my experience. In terms of the ones that have had previous Heller or previous myotomies, those I usually find the rate is higher, probably close to 50% requiring lifelong PPI. And that's been kind of my experience with it. And in terms of how does it compare with kind of other procedures, well, I guess I'll leave it to some of the surgeons to comment on in terms of after Heller and Heller-Dorr. But I haven't had any patients who have refractory reflux requiring a surgical intervention subsequently. And pretty much everyone has responded to PPI afterwards. Some require BID, some require once daily. But for the most part, truly PPI refractory reflux after POEM, I have not encountered. In terms of hypersensitivity afterwards, yes, encountered that, and they respond to TCA. But truly PPI refractory reflux after, I have not encountered. And whether or not it's more common, those people have the large hiatus hernia and you do a POEM on those. But those are the ones I usually would send to surgery kind of off the bat.
So we don't do POEM in Hawaii. So the patients that I've seen have gone elsewhere for their POEM procedure and then come back to Hawaii. But I think I think to reiterate, I think it's important to do a really good workup before you're going to subject anybody to an operation. But having said that, if someone's got really refractory reflux disease and you work them up and you're convinced it is reflux, that's a patient I would consider taking to the operating room and do some kind of partial fundoplasty on, if they really needed it. But it's essential to do a good workup to make sure you have the right diagnosis.
This is Roger. Yeah, I agree with that. I would confirm with the pH study, obviously. And I think that it is a reasonable thing to take this patient for a laparoscopic anti-reflux procedure. I'd probably do a toupee. That's my preferred approach with when I do a laparoscopic Heller. And again, I don't have experience with POEM either, so I don't know what the real incidence of that is. With respect to laparoscopic Heller myotomy with toupee fundoplication, which is my standard approach for achalasia when I do it, I do see occasional symptomatic reflux after after that procedure, but it's pretty uncommon. I'd say probably about somewhere in the 10 to 20% range, which is relatively consistent, maybe a little bit more than what's in the literature on
that. Can I make a comment here? Actually, a couple of comments, John, if I may.
Sure.
The first has to do with the distinction between chest pain, which we presume that was related to spasticity, versus chest pain following the poem, which probably is a reflection of acid reflux and sometimes behaves similar to heartburn. So I think it's important to really figure out if this is truly a acid reflux situation versus ongoing spasticity residual to the achalasia, because sometimes the poem may not resolve the whole process. And I think it is important to emphasize what are we dealing with, and that would be probably a repeat manometry to see where we are, as well as a pH monitoring. Personally, I like to measure the pH by a Bravo monitoring device, which takes me to either 48 hours or 96 hours. And that actually is giving me more information about the magnitude of reflux over time. I also would like to consider and bring to the forum what we need to do under the circumstances of a previously performed poem and the options that we have. That is either an anti-reflux procedure done surgically, or an anti-reflux procedure being done endoscopically, such as TIF, which has been, and I think is still being explored by some groups. So I think that would be something to consider and add to the list of options that we have, assuming that the patient has validated reflux. So I think those are considerations that I would put on the table at this point before we move on to the final decision about what to do. As far as the reflux, it's actually, I think, quite common. It's also common after a heller and a door. So it is not a minor issue and plagues all of us, including the patients. I think we need to remember that in the context of achalasia, we do not have any peristaltic activity to keep the acid out of the esophagus. So these patients are challenging in terms of managing them. I personally prefer the context of this case to do a BID therapy with a PPI. There's also a possibility that these patients may develop Barrett's esophagus as a complication of acid reflux. And I think to really put things in perspective, we need to be prepared that not only we have to deal with acid reflux, we may also have to deal with Barrett's esophagus. And in that situation, again, a BID therapy would be very important. So these are the thoughts that I'm entertaining as I listen to everybody, and I would explore them all in due course.
So I'll speak up just to kind of second George on that. In our experience, about 60% of patients say they have reflux, and about 30%, 33% have objective evidence of reflux. So you have to be careful about symptom reporting, and you should, if they come in to see you because of a reflux complaint, you should test them for that. It's not an easy test to do. It's not a standard pH test, and you need to do extra measures like a longer Bravo test or impedance monitoring as well. In our experience, we've done over 600 cases now, and probably about 12 patients have had refractory reflux that wasn't treated with H2 blockers or PPIs. We tend to start patients on H2 blockers because increasingly patients are resistant to lifelong PPIs, and see how they do with that, test them on the H2 blocker, again, see how their symptoms go, see if they have esophagitis, and then make further recommendations on that. I can also say that although short-term after a Heller partial fundoplication In the short term, reflux is unusual. Probably 85% of patients are reflux symptom-free and even objective reflux-free. Over the long term, partial fundoplications tend to deteriorate, and in the end, after 10, 15, 20 years, probably very similar, about a third of the patients will have objective evidence of reflux.
That's what I wanted to add before, because I believe to see that the long-term reflux of a hella door, we only do door, is pretty much the same symptomatic from a percentage share than initial poem. So I see 50% of patients after hella door 10, 15 years later who do have reflux symptoms. So I think this is not an initial question, this should be a long-term question. That might be pretty much the same probably.
I want to share some my experience from the Asian country, because I come from China. Actually, we did about more than 100 cases of POM per year, and the prevalence of reflux after the POM procedure actually is much more lower than that in the Western country. We have about 15 to 20% of the patient who will have the reflux symptom. However, under endoscopy, less than 10% of these patients who have the reflux symptom have the esophagitis. So a little bit different from the Western experience.
Great, great. Well, thanks everybody. We are going to keep on going with the case here, so I'll pass it back towards Micaela.
Great. So ultimately, the patient did undergo a laparoscopic toupee fundoplication or posterior 270-degree fundoplication in March of 2017. His reflux symptoms did readily improve after the operation, though he did again experience symptoms of dysphagia. Definitely better than his pre-POMM dysphagia, but it was new since the fundoplication. And with this, he developed essentially intractable belching and abdominal distension with bloating. Every time he would attempt to speak, he would be belching. He lost additional weight due to this, suffered anxiety from this, unable to work due to his constant belching, and ultimately actually went on disability. We first saw him, as I mentioned, in May in 2017. And during that history and physical examination, the patient was belching throughout the appointment. He was also spitting up saliva into a cup. He was visibly anxious. He did have mild abdominal tenderness throughout his entire abdomen, no evidence of hernias or anything pathologic in terms of his incisions. An exam was otherwise unremarkable. So this is kind of a broad question, but kind of what next? And then we actually go on to Dr. Kamal's kind of portion of once he initiated care with us here at Stanford, what we've done.
Okay, at this point, so given this situation, he's had the prior POM, he's had the partial wrap, he's miserable, but the reflux is better, belching constantly. What would people do as the next step here?
I'll start. Repeat his radionuclide gastrointestinal emptying study to see if he has a gastroparesis.
Yeah,
I would also do an
I
upper
would agree
GI.
with that. Go ahead, Roger.
Oh, sorry. Yeah, I totally agree with that, but I would also do an upper GI barium swallow.
One needs to keep in mind that gastroparesis pre-exists our interventions. There is obviously a very well-known concept that achalasia may involve the stomach, and I think that would be the appropriate next step, belching being a very significant symptom of gastroparesis. And I think in the context of the previous surgeries, POM, etc., it would be a very significant possibility that needs to be explored. At the same time, this fellow has been troubled by esophageal issues for quite some time, and he may have an underlying secondary gain to explain this degree of belching. I mean, this is almost unrealistic, and I think that other factors could play a role here.
Okay, so
We have pH study so far because I haven't seen it yet.
go. So we'll get here, and I'll pass this towards Dr. Kamal.
Great, thank you, Dr. Clarke. So our plan for our initial visit, now that we're seeing him at Stanford, is to do a repeat endoscopy, but this time at end of flip, and then do a manometry placement at the time of endoscopy, and then have a patient undergo a repeat barium esophagram, and then reassess after all the results on what we can do next. Next slide.
Okay.
Great, so this is the upper endoscopy images. So you can see that in the first image, you can see some frothy secretions. The lumen is mildly dilated. The lower esophageal sphincter is kind of on the bottom left. Everything looks pretty unremarkable. We can see the partial fundoplication on the retroflexion, and it didn't appear tight as the scope traversed kind of forward and backward motion on the retroflexion. And then the patient undergoes a manometry as well, and we can see that the lower esophageal sphincter is relatively hypotensive, doesn't look tight. The lower esophageal sphincter came out at 6.4. There is a mild separation of the fundoplication, but there's really no obvious pressurization. Relatively looks unremarkable, and although there isn't any obvious contraction or peristalsis, there is some kind of intermittent pressurization in the mid and distal esophagus on some of the swallows. And then the patient undergoes a barium esophagram. So the report of the barium esophagram is showing some smooth narrowing at the fundoplication site. There is some mild esophageal dysmotility noted with loss of stripping wave, some mild intraesophageal reflux, but no evidence of obvious gastroesophageal reflux is seen. So this is kind of the overall clinical course. So the biopsies from the upper endoscopy, the esophageal biopsies, are coming back with some mild lymphocytic esophagitis, with some focal parakeratosis, no candida. These are the flip measurements, which was one of the reasons for the repeat endoscopy. So it's an increase in volume from 30 to 70 cc's. And you can see as the volume increases, the diameter does increase, but it only reaches a maximum diameter of 14.2. But that being said, the distensibility does look great, and the distensibility at 70 cc reaches 5.4. Otherwise, the upper endoscopy, manometry, and barium esophagams were reviewed. So the clinical course, so now the patient's coming back for follow-up, and now he continues to feel miserable without any change. And his symptoms that he's describing to you is that he continues to have refractory belching, just not feeling any better. Dysphagia is an everyday occurrence, although it is better than prior to his POEM that he underwent. He continues to have intermittent regurgitation, intermittent chest pain, chest tightness when he moves around. He gets shortness of breath even with his belching. And in fact, he tells you that he was in the ER this past weekend. So now the question for the panel is, okay, given all these symptoms, what would you do now?
So no pH study and no gastric emptying study, is that right?
Not yet.
Yeah, I'll say that he'd had a gastric emptying study at the outside institution, both before and after his RAP, which were both normal. But we don't have a pH study at this point.
Yeah, a pH impedance study will probably be the best option, not rather than just pH alone, especially with the belching being a big part of the symptoms.
And just a question, and then during this time as well, what's happened with his cannabis use and his narcotic use? Has it changed at all? Because you were mentioning before the narcotics were seldomly used. Has that kind of now increased, or what's happening to that now?
Yeah, it's a great question. You know, his use of opiates during this was about twice a week, not every day, and the dose which he used was pretty low. If he stopped it for a period of up to two weeks, there wasn't any change. His cannabis use was more frequent, and was, you know, was at this point in time used every day. So we'll jump ahead towards the next slide, which may answer some of these questions.
Great. So after a discussion, so we kind of discuss with the patient potential options. So what we plan for doing is doing a repeat endoscopy with Botox injection, as kind of mentioned already, a trial of gabapentin, recommending some complementary therapy like meditation and mindfulness, and then a site consult. So the patient does undergo endoscopy repeat with a Botox injection of 100 units, and then comes back 2 months later. And now he feels worse. He has no improvement with the Botox injection, and belching is in fact worse. So now the options are discussed. One is doing a surgical consult to consider takedown of the fundoplication. 2 is an antibiotic trial saying that maybe he has SIBO given his bloating, belching symptoms. 3 is an acupuncture trial. 4, as discussed, is an ambulatory pH impedance study off medicines. And then the last option is continued meditation and work with psych. And so now I will pass it on to Dr. Zikos.
This was Botox of the esophagus or of the pylorus?
Botox of the esophagus. Apologies. Hello, everyone. Tom Zikos, nice to meet all of you. So yes, it was Botox of the esophagus. So so here's a pH and impedance study that we've kind of all been wanting, and is certainly a very logical next step. So I'll just kind of briefly discuss this. It was done for 48 hours off of therapy, kind of, at least partially to look to see if there's any residual reflux, as well as look to see if there's look to see what was going on specifically with the belching. So I don't know how well this is kind of projecting here, but I did want to sort of draw your attention to one representative episode of belching, and it looked kind of like a classic supragastric belch. If you look at the top right panel, you can see kind of he's sucking air down with the use of his diaphragm, and then belching it back up. So, and then you can kind of see similar patterns looking at the bottom left as well as the bottom right. So his belching did sort of follow a typical pattern that you would expect for supragastric belching, the dreaded supragastric belching. You can go on to the next slide here, and so we'll go over the specific data from the study. So there was actually, in addition to the supragastric belching that we saw, there was additionally elevation of distal esophageal acid exposure at 8.3, with obviously anything greater than 6 being, per consensus, definitely abnormal. He also did have, borderline elevated, I'll say, impedance events at 78. So, it's looking like, in addition to supragastric belching, also definitely had, increased reflux burden as well. There was a poor correlation between any of his symptoms that he recorded, including belching and reflux events. However, the supragastric belching that he was having was obviously strongly linked to his symptoms of belching, which is no surprise. Just to kind of step back and summarize what we've talked about and discussed so far. So we've got a guy here who initially presented with pretty well documented type 3 achalasia. He underwent a long poem, which, certainly I think we all agree was reasonable based on our previous discussions. He had very bad reflux after the poem that was refractory to therapy, underwent a 270-degree fundoplication. And then after this fundoplication, he now has this horrific and debilitating supragastric belching. So each way along the way, we're getting rid of one problem, and then another problem, potentially even worse, is popping up. He did say actually that the belching seemed to be worse than his GERD in the first place after the procedure. So now I'll pose the question to the panel. Have you ever seen this kind of presentation with achalasia, and what's your general approach to supragastric belching, and kind of what would you go ahead and do next? Anyone wants to take a crack at this? This may be a decent one.
Answer to the first question. Yeah. No, I've never seen this with achalasia. This is quite a case. Very impressive. And the only tool I know of in the toolkit for supragastric belching is really mindfulness therapy and behavioral modification. So it looks like he'd already had a referral to that. I guess we haven't talked yet about how much he explored that or how effective that was, but that would really be the next thrust. I think any kind of reoperation, I'm sure all of the surgeons on this call would be pretty hesitant to do. I certainly would be.
Any other thoughts on would anyone be interested in taking this guy back to the OR?
No. Go ahead.
Go ahead, Dr. Dan. Sorry.
Did the belching start after the poem, or because it sounds like it started more after the wrap than the.
Started after the wrap, correct?
Because I think I've never seen this with achalasia, but I've seen a few cases of this after patients having a wrap, actually, either because of some functional issues where they just feel tight and you start doing a lot of air swallowing and supragastric belching. That's leading to that I've seen before, but maybe the supragastric belching is more associated with the fundoplication more so than the achalasia itself.
Yeah, I would agree with Walter on that. So I also think, this patient's background, past medical history, and then having type 3, it's difficult because we don't operate on those patients as a primary therapy very often for surgery. I do agree. I've seen a couple of patients who've had fundoplications in the past, and when they come in, in this patient in particular, I'd be worried that does he have a small hiatal hernia that maybe doesn't show up easily, but just based on the fact that he's got poor motility is causing a relative obstruction during the time that it's herniated. And the people I've worked up with supragastric belching after fundoplication, often we'll find just a small recurrent hiatal hernia, but it doesn't take much in these people, and it is that vicious cycle, which is why often they end up in meditation and therapy for the disease. So I'd be a little bit worried about that, but obviously didn't show up on any of the studies, so maybe that isn't the case. But I would be more worried about the wrap in this case as compounding the problem for him.
And have you tried any neuromodulators at all since the fundoplication?
Yeah, we'll chat about that in a second.
Okay.
He had quite an extensive trial of other therapies that we'll chat about that.
It doesn't seem to be the fundoplication to me. You did physiology testing on it. It's not tight. It's not restrictive. I don't know what his barium swallow, if there's a timed barium swallow, his esophagus clears well, but obviously he's aerophagic. It can be psychological, it can be physiologic. Once again, I'd be highly suspicious about his stomach, the function of his stomach. Gastric emptying studies aren't notoriously accurate or precise. I wouldn't certainly agree with everybody that wouldn't want to leap in and do surgery on him. Maybe if you threaten him with surgery, he'll back off and go away, but I'd still be a little bit suspicious about his stomach. It didn't really look like it's his fundoplication, which on endoscopy looked pretty mild, and on endoflip looked extremely mild.
Yeah.
One provocative thought that I wanted to share with all of you: has anybody considered, or Tom, you're an expert in supragastric belching, but
that's definitely not true, just for the record.
The thought that I had was that you can put a temporary stent through the G junction, and that will bypass the surgery, the previous performance of a poem, et cetera, with these stents that can be removed in a week or two, and see what happens in terms of the belching that is so debilitating. So that's one thought. I don't think it has been tested, but stenting in the case of achalasia has been tested. So that's one possibility. The other possibility would be to consider during the study of the pH impedance, maybe you can change the environment, potentially create a period of time, let's say 12 hours of so-called stress-free situation, and then another 12 hours in which you try something else. Given the fact that he has so much repetitive belching, I am sure that the 78 episodes of impedance events, that wouldn't really translate to all of the things that he describes. I mean, he does this almost on command. In other words, he comes to the office, sees us, and boom, he has all these belching events. And then you take him away from the office and he goes to the bathroom and he's fine. So I think that it would be an opportunity to repeat the study, first of all, to demonstrate that you see the same results, but also to see how common is this when he keeps a report of his belching.
Yeah, very, very interesting thoughts there for sure. I think it sounds like, we all agreed conservative measures first, probably before, pursuing anything more aggressive. So we can, we can go ahead and talk about some of those other things that we had done specifically at our center. So over the next month, as we discussed, he was referred for behavioral therapy for treatment of supragastric belching. This is kind of a subspecialized treatment, so it's sometimes is difficult to find the right provider. And we did have some difficulty with that, but regardless, he did undergo a full treatment with, I believe, a speech language pathologist and techniques to try to stop the belching. And that didn't really seem to be effective. He was also tried on cognitive behavioral therapy as well. Minimal success. We tried numerous neuromodulators, as we were discussing, because the idea that there was some visceral hypersensitivity that maybe was triggering a supragastric belch, including nortriptyline and pregabalin, all with dose escalation. In the realm with similar to what George was saying, we didn't put a stent in, but we did try dilating him again with a standard endoscopic dilation up to 20 millimeters. No change with any of this. We repeated the barium esophagram, and things look pretty unremarkable, pretty similar to before, with an unchanged smooth narrowing at the fundoplication, with maybe some mild delay in contrast passage, but compared to prior, but nothing that was all in all that remarkable. So, given sort of the failure of the standard things that we often do for supragastric belching, behavioral and speech therapy, trial of neuromodulators, things like that, and some other things that we've tried, like the endoscopic dilation. I was wondering if the panel had any other thoughts about how to go forward from here, or any other things that we would try. I know we have already discussed some of the other thoughts going forward here, but I may bring up the idea of, I'll bring it up again. I know that people are hesitant to do any surgical intervention, but perhaps pneumatic dilation to help open up the sphincter a little bit, with the idea that this all started after the fundoplication. And would anyone at this point consider a fundoplication takedown, or even go further and consider esophagectomy for refractory belching? I think I probably know that some of the thoughts on this, but just want to get the panel's thoughts here.
Well, I would certainly be resistant to a fundoplication being undone or redo or whatever, undo. That's why I proposed the idea of a stent that can be removed 2 weeks later, trenches the sphincter, or the creation of a new sphincter, and that potentially will give us some answers. The other thing we have not really done, I don't think, is the use of tranquilizers, such as Ativan, Valium, or any of those things. I have personally used those in achalasia quite frequently, actually, for people who are not complicated like this, but for people who have significant degree of chest discomfort or pain, or whatever you want to call it, after any manipulation with achalasia. Typically, the people who present to begin with chest pain do not do very well with surgical interventions. And now, of course, with the poem, gives us a little bit more promise, but I would consider a standard course, not of neuromodulators, but tranquilizers. And I wouldn't be surprised if he responds to that.
Sometimes I treat these supragastric belcher almost like ruminators in a way, so I assume they've probably done diaphragmatic breathing associated with the needle therapy. And also the other one is baclofen. I've used that a number of times with people with belchers and also with ruminators. And so that might be something to consider as well if that hasn't been tried.
Dr. Clarke, do you know if he got either baclofen or any benzodiazepines?
So second question, yes. He had been taking baclofen actually at the time that I saw him initially based on more spasm issues separate from the esophagus. We did a dedicated trial of that and ramped it up pretty significantly without a change in his belching. Tranquilizers, I believe he had at one point along the way, but I'm not 100% sure of that. I'll have to look back and see. You know, what we had kind of scratched our head with a little bit was we had spent about 10 months really trying to focus upon doing medications to make them less sensitive and trying to get behavioral therapy going, and didn't really feel like we made any improvement at the end of that 10 months. And when he had the barium study repeat, you know, there was not a marked difference versus the one, but they did comment that it appeared that things were a little more slow in terms of emptying from the esophagus than what they had been prior. And he did comment specifically that his belching was only since the wrap, and that this was definitely worse than what he had had from the GERD before he got the operation.
Just to answer the esophagectomy question, certainly you wouldn't ever consider that. His esophagus is not dilated. There's no replacement unless he's willing to live with a spit fistula for the rest of his life. There's no replacement that would be better than what he has. I think the target organ would once again be his stomach, probably. If he's going to have a radical surgical treatment, it'd probably be gastric emptying procedure or a subtotal gastrectomy. I was kind of curious, you didn't mention the rest of his GI function. Does he have evidence of generalized GI dysmotility, constipation, bloating, things like that?
No, not really, actually. It's interesting. For all of his profound symptoms, he really doesn't have a lot of bloating, and he didn't have any change in bowel function in the course of this.
I agree with Lee. We need to really explore the rest of the GI tract because, again, in the context of achalasia, you may have a pandysmotility involving the stomach, small bowel, as well as the colon. And they can be subtle, and they're not really reported because of the central characteristic of the disease, which is mostly the esophagus. And I also, given the known fact that there is not really good correlation between gastric emptying scan and symptoms, I would empirically try a pyloric injection of Botox to see if, let's say, even transient improvement of gastric emptying would be therapeutically successful.
Let me move on here.
All right, thanks for all of your opinions. Actually, I think that they're very insightful. So he was actually he did actually seek a second opinion at a different but also sort of well-established esophagus and motility center from ours. And you know, given the fact that a lot of this did start after the funduplication, you know, we mentioned the potential confounders of, you know, changes in motility after the funduplication and things along those lines, and possibly underlying dysmotility. But, you know, despite that fact, the other center decided to go after the funduplication portion of it in the LES a little more. So they did actually trial pneumatic dilation to 30 to see if that would be helpful. He also underwent a second round of behavioral and swallow therapy for belching. He tried buspirone as well, and despite all of that, there was absolutely no improvement in any of his symptoms. And then came back to, and then, you know, there was also a decision at that point, you know, maybe to pursue, you know, a third round of biofeedback and diaphragmatic breathing therapy and kind of an in-office setting. And I believe that Dr. Clarke actually led the charge on this one, and actually brought him in several times and went through various diaphragmatic breathing and other techniques to try to stop the belching. And also we tried sertraline, and, you know, despite all that, that also was ineffective. Over the next year, we escalated his sertraline, transitioned him to an SNR, a selective serotonin norepinephrine reuptake inhibitor. That was ineffective. Continued in-office biofeedback. We sent him to see our pain management physicians, you know, despite the fact that it was primarily a belching issue. We tried low-dose naltrexone and even ketamine infusions with an attempt to dissociate him from his belching episodes, and that was also ineffective, unfortunately. So nothing really worked, and it kind of in the background of all these therapies, he's also, just important to bring up the rest of his medical issues. He's also suffered some other issues, including knee injury requiring surgery, an episode of diverticulitis, and some back issues necessitating a spinal cord stimulator, and as well as carpal tunnel surgery as well. So there's a lot going on besides just the refractory, presumably supragastric belching here. Next slide. So just to kind of bring us up to present, he remains absolutely miserable. Basically anything can induce belching, whether it's speaking, any movement. He did try to get a job working as a welcome person for a grocery store. However, he couldn't be hired even to a job like that because he was just constantly belching during the interview. Right now he's at home, miserable, on disability, desperate for any next steps. At this point, you know, at the current, you know, we did opt to kind of repeat the workup again, repeated the barium study, which again, you know, did look similar to the prior barium study we just discussed, a similar non-fixed narrowing at the funduplication site with some delayed passage of contrast. Endoscopy again with mild esophageal dilation and acanthosis. Slight contraction at the LES at 43, and funduplication with slight angulation. All in all, nothing looked too abnormal though. Biopsies were pretty unremarkable, minimal esophageal inflammation. Endoflip showed absent contractility at kind of the standard 60 cc's of distension. You had diameter of 9.1 and a distensibility index, which is maybe perhaps a little bit borderline at 3.0, but it's still kind of above what we usually consider the upper limit of normal. But as you move up towards 70, the diameter increased to 15.2, and the DI was well within normal of 5.4. We repeated again the pH and impedance study, actually this time for for 48 hours off of PPI therapy. And this time there was really minimal acid exposure and impedance events, which is slightly in contrast to the prior one. But he did have continued refractory supragastric belching, which seemed to be the theme for him. So basically, you know, as we talked about, remains miserable, constant belching, no improvement with all the neuromodulators, behavior modifications that we talked about. He's desperate for anything to make him at least partially better, and you know, the question is what to do at this point. You know, just at least considering the fact that anytime we've sent him to the OR, it's been kind of a very long, arduous, painful recovery over months and months and months. So, you know, I think that, you know, there is hesitation among everybody to take him for any type of surgical intervention, especially given the situation and given his prior issues with this. But at the same time, he hasn't really responded to absolutely anything that we've tried, and we're sort of running out of options, and he's absolutely miserable and basically more or less can't really function very well as a human being right now. So with that said, you know, our questions now to the panel, you know, I think we've been kind of talking about this. Would anybody ever consider reversing his fundoplication or doing some other surgical intervention like esophagectomy now, or do you have any other thoughts about going forward?
I'm going to weigh in for a second on this one.
Sure.
And, you know, I would say, and this is, you know, obviously a very challenging case. And when I'm sure, you know, when you see him in clinic, and you see how miserable he is, you're tempted to want to try to help him. I would say, you know, if you look at the entire course of this gentleman, I'm not sure he's been helped very much by any of our interventions. I'm not sure he's better off now than he was before, you know, anybody kind of touched him. So I think, you know, we tend to be optimistic about our outcomes, and we tend to see the positive aspect of what we do and be like, no, but he got better from this aspect, and he got better from that aspect, when there's this huge amount of things where he actually got worse and worse over time. So I would say overall, I'd be extremely cautious about being aggressive in any way, or even getting close to that in terms of redos, you know. And I know that you guys, you know, put in some questions in here to be a little provocative. You know, I don't think any of us are gonna even consider an esophagectomy on him, but I think it would be, you know, inconceivable to think of doing that on him. And one, you know, I think there's been some fantastic ideas from the panel. I am also thrilled that I have, you know, that looking at who geographically is around here, you know, brilliant surgical colleagues that this gentleman can be referred to on the West Coast and not too far across the pond. But I would also, joke aside, I think I agree with Walter and Ken about the wrap, but I also think this is not just intrinsically a wrap issue. This is, you know, something that kind of was pre-existent, and if anything, probably kind of got worse because of the wrap. But I think there was some underlying things that you know, even if you were to do a perfect operation tomorrow, take him, undo his wrap, and put him, you know, back to where he was before the partial fundoplication, that, you know, he's not going to come back and be perfect either. So
yeah, this is Roger. I agree with that. Yeah, and I you know, want to go back to, in particular, I mean, he had a pretty aggressive dilation at one point when he was referred to the next center, it sounds like, and with absolutely no improvement, which makes me concerned that doing anything with the wrap would also result in no improvement. You'd expect to see, I think, if the wrap were the issue, I think especially given that it's a partial posterior fundoplication, let's not forget that, you know, a dilation should at least result in some improvement. You know, rarely do you get significant problems from a partial fundoplication other than the fact that it sometimes doesn't work. You know, that's the problem you typically see. So I completely agree. I'd be very hesitant to take down that wrap. And an esophagectomy, I mean, you know, the problem is supragastric belching, then it'll be gastric belching from his conduit. You know, that's not going to change either, I think.
I have simple question. This very challenging case. Did you test his gastric emptying? Is his gastric emptying delayed or normal?
So we didn't. I don't think we included it within the slides, but it was tested after the fundoplication was done, and it was normal at that point. I don't know if, you know, today's. Correct me if I'm wrong, you know, Dr. Clarke, but, you know, I think it certainly is a consideration to repeat it at least today. I don't know if he's had one done more frequent or more recently.
Yeah, I think, you know, he's probably had it done 2 or 3 times total in the course of his workup. It was normal for all of those, but I believe it has been at least 1.5 years or 2 years since his last gastric emptying study.
Thank you.
Yeah, and I would agree with Dan. I think Dan summed it up very well, that no matter what you do, I think the symptom that's bothering him most now started after some of the therapy was instituted, and it's almost taken on a life all its own. And esophagectomy, as Roger said, I don't think would be an option in my mind. I wouldn't even be anxious to do anything about his fundoplication because he's had dilations. I would pose a question to those of the people out there who do POEM, and how, you know, when we do myotomies, we emphasize going down onto the stomach 2 to 3 centimeters. And is there any risk to not getting far enough down on the stomach? And is this an outflow issue beyond the GE junction because you didn't get far enough down? And I'm just posing that question because I know we emphasize it. I've seen a couple people who were early in POEM experiences who maybe they didn't get far enough down on the stomach, it seems. And is there any benefit and consideration of that at all? And again, not doing POEM, I don't know the answer to that question.
I presume you have a timed barium swallow and that was normal? His esophagus clears okay? That would kind of rule that whole incomplete myotomy issue out.
Yeah, it's not normal completely. He clears everything within the 2-minute mark, but he doesn't. He does have some residual at 1 minute.
That's pretty normal.
There are also a couple of provocative studies right now. I'm not really familiar with that, like a rapid swallowing testing during the time barium swallow. Have you considered that?
Sorry. So we have not done the rapid. We do that as part of manometry now for each one that's done. But his one manometry that we have was done, I believe, in 2017, and that wasn't. That was not then associated with our protocol for it. We've repeated most of his studies since that point, but I don't believe the manometry has been checked again since then.
So I'm not sure the multiple rapid swallow per se would give us too much extra information, because that's more, because I don't think we're wondering about his esophageal reserve, which probably is not much left given his achalasia. So I'm not sure if that they will actually tell us more. It's probably not going to be a good response there.
On the other hand, you're diagnosing him as supragastric belching, and can you really tell that completely on an impedance study? There's still I'm still suspicious about his stomach. The supragastric belchers that I've seen had massively dilated esophagus, essentially a second intrathoracic stomach, kind of obvious air swallowing issues to kind of force pressurize the esophagus. And so their manometry would show intrathoracic pressurization of the esophagus. His, normal caliber esophagus, not a hyper pressurized esophagus, doesn't seem to really fit into that. And that being considered, sometimes in these air swallowing patients, non-supragastric belchers, but kind of gastroparetics, a trial of a PEG tube for decompression might be worthwhile. But I don't know, you can tell me how sure you are that this is supragastric belching.
Yeah. Oh, sorry. Yeah, we're pretty sure. I'm going to go back and show the slides from the pH impedance. Sorry, it'll take me a second to get to it. But going back here for this one, if you look here, it does seem like the air is coming in from the mouth and going down. Now, to your point, the pH impedance catheter that we have does not enter the stomach. It stays just in the esophagus. So we can't tell if it's going down to the wrap and coming back up, or if it's hitting the stomach and coming up. But we can tell the air is being drawn from the mouth in. Because it does look like we've got that directionality. It's not perhaps as clear on this picture, but if you really zoom in, it does seem like this is coming from the mouth first and then going down.
On the other hand, John, on the tracing up above, on the pressure profile on the right side, it looks like he has intragastric pressurization. Certainly the pressure profile would seem to indicate that at least a little bit, although as you say, it's not placed in his stomach, but I wonder if that's a possibility.
Yeah, and he does have, if I go up again a little bit, he does pressurize the esophagus more than you'd expect given diameter and barium. So if we look here, you can kind of see in this last image in the lower corner, he does generate some focal segmental pressure in the course of swallowing. Now we didn't capture in this particular study any of the belching episodes, but he does generate some pressure despite the fact that he does clear pretty decently and he's not terribly dilated.
I wonder if this will be a patient that will be where, if available, ambulatory manometry will be useful to look at, look at intragastric pressure and whether or not that, that will be associated with these episodes.
Yeah. Unfortunately, we don't have access to that at our site. Does anybody else have access towards the 24-hour manometry protocols?
John, I'm going to try to argue in the direction of this being a psychologically induced phenomenon. And I would propose very cheap ways to find out if he belches when he is with us versus if he belches when he's not with us. In other words, if he's at home, and to what degree this persistent and repetitive phenomenon is happening only when he visits the doctors versus when he is at home or when he is in a waiting room or somewhere else. Because if I heard correctly, this is a phenomenon that happens so frequently that it's kind of unbelievable. When people with abnormalities in the physiology, they have intermittent phenomena, not upon command. And I think that this is a feature in his case that makes me suspect that we're dealing with some kind of a secondary gain as opposed to a true abnormality. I mean, even if we have somebody with pathologic belching, they don't do this so often. And I think that if you look at, let's say, the barium swallow, at the time that the barium swallow was done, he was not belching, he was fine. Or when he was in the operating room or before the operation or after the operation for his diverticulitis, was he belching continuously? I mean, to me, that's an unbelievable amount of belching. to cause such a reduction in his quality of life or his inability to work.
Yeah, I think, you know, there's definitely there's a strong stress component to it, and he does not belch at night, for instance, if he's sleeping. It's during the in-office behavioral therapy that we tried, I generally could get him to stop belching in the office. The problem was, as soon as he left the office, he couldn't keep it going at all in any way. So I think you're definitely right that there is a stress component. I don't get the sense that there's secondary gain per se, but that being said, that's often very, you know, challenging to assess in clinic, and I might not have picked up on that, but there's definitely a stress component. And we have gone down the route of, you know, there's been 3 separate behavioral therapists plus the in-office eval. We've tried an SSRI and SNRI. We've gone down the route also of treating GABA. We've had psychiatry see him and follow him throughout this whole thing, and pain management has also seen him as well. So I'm not sure what I would have to offer next from the stress standpoint, other than doing benzos, which, you know, I'm not sure we've tried yet, and we certainly could consider. But your point is well taken.
I mean, belching should be something that you can actually visualize. So if he is somewhere that you have a little camera, like traffic lights or something, you can actually see that. It's not something that is minor. And I'm sure he has something that's visible when he shows up at the office, you know, with the doctor present, as opposed to the waiting room when there's no doctor there.
Yeah, you know, I think that his stress associated with this has escalated to a point where he's in this feedback loop now, where his fear about belching has increased the frequency to a point that it now is present in most circumstances. And he'd say it's present when he's not stressed, but I think he is stressed about you know, he has stress about this possibility, and it's now somehow cycled in a way that's, you know, been challenging to break.
Is he still with a BMI of 30, or he has lost weight?
He has not lost weight, so his weight has been approximately the same throughout this whole thing.
So he's eating with the degree of belching that he's doing?
Yeah.
Oh my God, how is that possible?
I'm not sure he is. Well, let's we have some polls, and why don't we take some polls from the experts and from the audience, and then we'll open this up towards the floor in terms of questions and discussion. So, Frederick, could we start with the first poll?
Sure. So the first poll, shall we come back to the first question? So the preferred therapy for achalasia, shall we start with this one?
Sure.
Okay, so you should see on your screen the ability to vote for one of the answers. Okay, maybe 5 seconds more, and I will end the poll here and share the results.
Okay.
Can you see the result, John?
Yep. Yeah, well, it looks good. Is it? So I can't tell. Is it visible to everyone with the results?
Yep.
Yep.
Yes.
Okay, great, perfect. Let's move on towards the second question. And I think everyone would say no, obviously, for the second question. But the first one, I'm curious, and just keep in mind that his belching did start after his wrap. It was not present prior, and he does feel he's overall doing worse now than before he had the operation. But there's all the various red flags that we've talked about throughout the way.
I guess the question is, would you consider reversing his fundoplication and see if that changes?
Okay, let me share the results with you.
Okay.
So clearly there's 41% of gastroenterologists and 59% of surgeons in the room.
Yeah, it's interesting. So the some points that we didn't talk about. So his active issues besides the achalasia in the last year, in many ways he equates them to some extent, at least partially related to these types of issues. And so his pain, for instance, he feels is musculoskeletal from the belching. His knee injury and operation he felt was secondary to belching, leading to a fall. So this is, that's factored in, but any operation he's had has set him back to a point where it's been a 3 or 4 month recovery. So his carpal tunnel release that they had said would be just a very, very minor issue. Literally, he was pretty much debilitated from that for about 12 weeks. So, which makes any operation that he has to take down the wrap, we could probably go in with the expectation that he won't do well and he'll likely have some post-operative issue.
I have one question that I would love to hear people's opinion about this. Knowing what happened to this patient, thinking back to initially when he was diagnosed with type 3 achalasia, when doing the poem, would you still have routinely kind of jump into doing a long myotomy right away routinely with these patients? Or, do you think that kind of snowballed into more issues? When you do a long myotomy, likely you have more reflux afterwards, then may increase the chance that the patient needed the fundoplication that might have led to sort of his current state. We know that sometimes some of these patients who might have some spastic contractions, if you just relieve the outflow obstruction, sometimes they might restore some normal peristaltic fragments in the esophageal body. Is it worth for these patients to not go for a non-myotomy right away, just relieve the outflow obstruction and see how they do before deciding kind of whether or not to cut the distal esophagus as well? I just want to see what people's thoughts are on that.
Well, I think for the type 3s and this guy, I would have, again, just based the myotomy on the manometry. So depending where kind of the spastic contractions start, that I wouldn't kind of alter it based on those particular concerns. I would base it on the manometry really, and ensure that I get the entire kind of segment that's spastic, because then you'll see some of the ones that you try to do a limited myotomy, they'll then often come back with some symptoms, and you'll do the manometry and you'll see that proximal spastic segment, or the ones that have had Heller in the past who then have kind of recurrence of symptoms or not complete resolution of symptoms because they have a proximal spastic segment, and then you have to do something else to them. So I think I would still do a complete myotomy based on the manometry in terms of cutting the entire esophageal spastic segment and ensuring a complete gastric myotomy as well, because in general, that's to prevent them from getting recurrence of symptoms and requiring another treatment subsequently. This is, a particularly, rare, unfortunate case. But I don't think in terms of if the plan was to do a myotomy in this particular patient in the beginning, which you can argue whether or not should have been done or not with everything else. I think the myotomy that was done seems to have been appropriate and wouldn't have changed it, I think.
Very well said, Robert.
Yeah, well, it seems like we have some experts within the audience as well. I know Dr. Ismail and Felix and Lee and Sloan, et cetera, and there's more as well. So we wanted to open it up to the floor as well. And if anyone wants to either share their thoughts or ask questions, please feel free to.
Can I just make one comment just about this patient in particular? I think just at this point, I think the most beneficial thing that's going to be done for him is basically the relationship you end up having with him. You're going to have him for life. I think this is not going to be someone that you're ever going to stop following. You're going to have to book 30, 45 minutes for them in clinic every time. And I think it's one of those things where we as well have to kind of prepare mentally and go in with a somewhat positive attitude in meeting with them, because it's going to be the therapeutic relationship with this particular patient. You're not going to do anything to this guy that's going to make him feel great, regardless of whatever it is you can possibly do to him. He's never going to feel great and never going to kind of be completely, symptom free. So I think you're going to have to be kind of, you're stuck with him, following him for life unless he moves, but you got to have a kind of a good therapeutic relationship with him and book a lot of time for him in clinic. He's going to be someone who sees the med student and then the resident and then the staff, so they can get out all their kind of angst and frustrations and feel that they're being listened to. And I think that's probably going to be the most beneficial thing for him at this point, with probably periodic some kind of essentially trial of domperidone, trial of something, just to something relatively benign that's going to make him feel that you're at least trying to do something. But I think that's going to be the best that can be done for him.
Yeah, that's true. It's a good point. And, we've kind of gone down that road. He sees us probably be between 4 and 6 times a year, and most appointments are well past what's scheduled. And he does generally see everyone that's involved with the team. And that has been helpful. And to add as well, he's actually a lovely person, and he's not a bad visit. He's just very symptomatic. George had talked about stent placement as being a possibility, and is that something others would think of in this situation? I could say that's not something that we've tried or thought about previously.
Hey, Josh Sloan here. So if it weren't for his persistent symptoms to basically everything that you do, I think that that's certainly a reasonable approach. But since he has a symptom of something to anything therapeutic, I would be hesitant for that as well, because I think he's just going to be miserable when you put that in, and then he's going to be coming, the next day saying, I need this out. So I totally agree with the previous sentiments of, he needs long visits and a lot of just attention when he's there. And then certainly positive suggestions that the cognitive behavioral therapy can be beneficial, so that he is also getting that psychiatric influence as well, which again is just going to be that therapeutic relationship too. So I think that that's the approach that I would go. If he didn't have symptoms to literally everything, then I would consider, at least from a GI standpoint, maybe undoing the fundoplication. But given that he, again, with a carpal tunnel, he's out of commission for months, there's I don't think touching him would be beneficial at this stage.
Hello, hi everyone. Justin here. It's been a really fantastic case discussion with so many twists and turns. I do have some experience with supragastric belches that are similarly difficult, and many of my colleagues at the so-called combined dysphagia clinic often have sometimes difficulties even with the speech pathologist or the speech therapist being there helping them. But if they are not really compliant to those interventions, then it's also difficult. But I have one or two points which I would like to highlight. One is that if the patient have causes that may result in a lot of gas, for example, small intestinal bacterial overgrowth or any other reasons that require him to, say, belch, that may potentially worsen any supragastric belch that they may have. Some of my patients who did have supragastric belch initially was because they are trying very hard to belch out whatever gases that they have. Like in this particular patient, he has on proton pump inhibitor for a long time, and we do not know whether he may have small intestinal bacterial overgrowth and all the other gases. So that is one point. My other point is, I wonder if his marijuana use or the cannabis use, does it have any effect on the upper esophageal sphincter, like what it does on the lower esophageal sphincter? Maybe I would like to hear from other colleagues about some of these points. Thank you.
That's actually a very important point. Thank you for bringing it up. The possibility of bacterial overgrowth is very real, and a trial of Xifaxan for 2 weeks would not hurt anybody. We know that gastric emptying can be impaired in the patient who is using marijuana. I have not really seen or heard of the possible effect of marijuana in any of the sphincters of the esophagus, but I think you bring up two previously undiscussed points that I think they're worth looking into.
Okay, I think we are nearing the end of our time period. So we wanted to thank everyone, the panelists, the audience, presenters. This was a great discussion. And in terms of what to do with the patient, I greatly appreciate the feedback. And we'll pass everything back towards Robert.
Thank you, Dr. Clarke.
Thank you, Micaela.
Fascinating case. Thank you so much.
Well, the only thing I wish to add is that I was right, and this clinical case presentation and the discussion that's followed reflect the value of this initiative of the platform, the OESO-SEMPIRE platform, and its role as a trailblazer, I think, in all fields of multidisciplinary esophagology. And I wish to announce, as of now, the next session, which are already scheduled, and the first two promise pulsating interaction between different parts of the world on cancers of the esophagus. On October 3, from Kenya and South Africa, led by Russell White and Vikash Sivaram, and October 29, from Beijing, led by Professor Jeho and Yusheng Mao, who was here today, with different teams from Asia. And what I can say is simply get ready as of today to take part in these two events. And thank you for being here today.
Thank you all. Thank you, John, for this fantastic organization, and thanks to all the panel here for these great discussions.
Thank you, Frederic. Thank you, Frederic, for all you brought for the running of this session and for the satisfaction of all the attendees today.
Have a great day and see you next time then.
Thanks everyone. Bye.
Thank
Thanks
you.
all. Bye.
Thank you. Bye.